Hi, E.
Hi.
Thank you for presenting to us this week, by the way. Thank you so much. Nice seeing you again, too.
Yeah, likewise. How's everything? Hey.
Everything's good. Busy. I'm sure, as everyone else, busy. Numbers are picking up. But otherwise, I guess good ultrasound pathology. That's the only good thing out of all of this. So,
Yeah, yeah. I think it's taking me away from Christmas cards. uh, so that's good. Preparing for holiday cards, sending out and everything. So, I had noticed that this session, after the session, there's the session with Columbia,
yeah.
that they have their own thing going. I don't know why we don't combine these. So,
No, so Columbia has like the ultrasound grand rounds. I think it happens only once a month, I think. Or I think actually, I got to check. I think it's quarterly. They don't have a monthly.
yeah.
Because they always get invited. And I don't see it every week, and I don't think I actually see it every month. But I'll double check with Lori. But I think it's every quarterly that they have it, and they have it at 2 o'clock as well.
Yeah,
Yeah, but
I,
yeah,
I don't know how you keep this up every week. I mean, this is like a lot of work, dedication. Good for you.
that's just a lot of collegial harassment, is the way I call it.
I know. Pretty soon we're gonna run out of topics to talk about. We have to be
That's what I
creative.
thought too about a year ago. I thought, and one of my colleagues here thought too, but I don't know. I've been waiting for that to happen so I can like meet up, but every week seems to be something different so far. So I guess I'll keep it going as long as I can, I guess.
Yeah. Well, good job, Henry.
So we'll give everyone to like usually 1:05, and then you can share your screen, and then we can get going.
Okay, sounds good. Just let me know when. Okay.
Okay, thanks. Good afternoon, everyone. Thank you for joining this week. Actually not a reminder, just an announcement. So next week we'll have Dr. Whitmore from Minnesota presenting, and after that we'll take a 2-week break just for the holidays. So next week will be the last session of the year. So I'll send another reminder during an email next week as well. But today we're fortunate to have Dr. Ee Tay from NYU presenting this week. So thank you so much, Ee, for presenting again to us, and you can take it away.
Hi, everybody, and happy December. I'm going to go ahead and share my screen. Okay, and this is very informal, so please feel free to interrupt at any time, and I may even ask you questions and things like that, so feel free to participate. So this week, we're going to talk about pelvic ultrasound. Is this pediatric ER related? Maybe, but this is going to be in the eyes of me in the world of pediatric ER. So we're not quite, this is not our thing that we like to do, but we do see patients over at NYU, we see up to 21 years old, and over at Bellevue, we see up to 24 years old. And so sometimes that we do get patients, female patients that would require GYN pelvic ultrasound. So this is just an overview according to a pediatric ER physician. Okay. Okay. No, I did that. Okay, so the objective of this is we're going to go over pelvic ultrasound in the PEM world, transvaginal versus abdominal, transabdominal ultrasound probes, and the basic views that we will be seeing, anything that's related to pregnancies and associated complications related to pregnancy, and also dabble on just basic GYN ultrasounds. So the probes that we generally think of using when we do GYN ultrasound is the transabdominal probe that you see, the curvilinear on the left side, and also as well as the transvaginal or the endocavitary probe that we see. And so this comes with different names. So endocavitary probe, cavity, intracavity, vaginal, transvaginal. And when I give this talk, sometimes we actually do use this probe for other things, such as we can look for anal fissures, using this probe around the anus, looking for if there's any lesions, and also for your abscesses, so that for any incisions and drainage. So in that case, when we're looking at any types of peritonsil abscess, we don't want to say, I want to stick a transvaginal probe in your mouth to look at for your abscesses, but then we call it an endocavitary probe. But this is high frequency. It is with a curve to it. And then so the bandwidth is about 6 to 9 megahertz with a scan depth of 13 to 15 centimeters. So to compare all the different probes that are out there that you could potentially be using, the curvilinear on the left side is a lower frequency, whereas a transvaginal on the endocavitary probe on the right side is 6.5 megahertz. Okay, so and this is just a different sequences that are actually produced when they produce as a sound wave between what's in the middle, the curvilinear, and the linear, because the endocavitary probe is considered a linear probe because of the high frequency. So what do we see when we actually use this probe? So one indication that this is an endocavitary probe is if you look at the very top, it's round, it's curvilinear, smaller footprint, so that you can tell that this is a smaller footprint than what you would see with a curvilinear probe. So that this is an indication that this could be an endocavitary probe. Plus, it's looking at the uterus, so that gives you a strong indication of what you're using. And as you can see that the smaller footprints that you can see for the endocavitary probe. The thing that you see here, you'll notice like a notch on the top of the probe here and here. So this is an indication of where you would put your probe based on your screen. One thing I do have to tell you that they've decided that there is some construction that may be happening upstairs from me. So if you see any, if you hear any extraneous sounds, I really apologize. So the way that you hold this probe is kind of like a gun, as this gentleman is holding it, and then you kind of turn it So before you do an actual study, there are a couple things that you do need for sanitary reasons. Gel. They also come with like a condom sheath of some sort that you can put over the probe that you can use to protect the probe and the patient for any type of extraneous contaminations. So some of the condom sheaths have gel in them, while others do not. If they don't, then I would strongly use a sterilized, those little lube package rather than one of these lubes that's been out sitting there. And then you're sticking that into the patient during a endocavitary, like a transvaginal exam. That just doesn't seem right. So please use some like a package lubrication. So the way that we actually describe this is clockwise. So 9 o'clock, 12 o'clock. So generally when you insert, I generally like to hold it like a gun and insert into the cavity. And then you know that the pointer, which is supposed to be where the thumb is, that at the top of the probe is generally at 12 o'clock. And when you want to look at what's going on the right or the left, I usually turn it to 9 o'clock position, because that way that I know my indicator probe is to the left of the screen, so that it can give me, so I know how I'm oriented. And here's another look of what you would be seeing. So this, so if you look at the footprint, which is very small here, it is, this is a sagittal view. So then the rays are going kind of up and down. And then, so this can be very confusing, disoriented at times, but with practice, I think you get better oriented. And then, so the indicator is on the top of the screen. So what you are seeing is generally what you see here. At the bottom, you see the longitudinal or the sagittal plane, and then the indication of where the dot is on the top of the probe is to the right of the patient, which is on the left side of your screen. And the same thing with the transverse. So if you turn the probe to the 9 o'clock position, and then you'll actually see the transverse plane. So the image looks different. Okay. So again, this is probably another picture just to drive the point in. So the sagittal as well as the transverse. Again, your pointer is important. So right here, they actually have a condom sheath that has gel in it, so that you don't have to put any external gel on the outside, although sometimes you can put like a KY jelly to use so that it can enhance your image. And then, so what you see here, again, this like in the sagittal, is you see the uterus and you see the endometrial tripe in the middle. And we do a transverse, which is to turn the probe to the 9 o'clock position. And then you see the uterus and then the endometrium in a different view. Okay. So this is generally what you would see on your image. This is the sagittal view. And as you're going in, you'll see here you have your uterus, and then you have the endometrium in the middle, which is the stripe here. And then between the endometrial stripe and then the rest of the uterus is what we call the myometrium. And then so the cervix, you see the cervix here, and then the fundus at the very end of the uterus. So the pouch of Douglas is where your fluid may accumulate. Okay. And then here's another image. So to refresh yourself, the image on the left should be transverse, and then the one on the right is sagittal. Okay. And the stripe generally is a very thin line. And then when you have something inside your uterus, this is what it generally looks like. Okay. This we probably have seen many times. Okay. So the other way that you can evaluate for patients is using a transabdominal probe. You can use a phased array, or you can use, if you don't have a phased array, you can use a curvilinear probe. And the arrow indicates where the indicator on your probe is. Okay, so, and then this is what you would see. If you notice on the top that the footprint is much bigger than you would see for a transvaginal probe, and then so you can see a much deeper organs. So you have the bladder, and then here is your uterus. And then you can do some measurements for your uterus, and then in the middle is your endometrium, and this is a transverse view. Okay, and again, and if you turn the probe around, and this is what you would see. Okay, so So sometimes your ultrasonographers, when you send your patient to the ultrasound, they always say you want to have a full bladder when you're using, taking a look through a transabdominal image. And this is because they want to use the basically urine in the bladder as a way to conduct that sound wave so they can get a clearer picture, which is what's indicated here. So then here it looks like a very full bladder here, but then you can actually have a really nice picture of the uterus, and they're measuring here the uterine, the endometrium. Again, the same thing here. This is not as clear. Generally, you don't have as clear of an image when I do these using transabdominal versus endocavitary probe. But the full bladder does help to try to take a look at the image to optimize the image. Okay. And so this is, if you look at the probe size, so what do you think this is? More of a transabdominal or an endocavitary probe? I'm going to tell you this is an endocavitary probe because of the smaller footprint. Okay. And then, and so sometimes you may see images where you actually have fluid collections in the pouch of Douglas. Okay. And so when you actually start seeing organs or pregnancies and whatnot, or findings, this is when you're starting to take a look at what's going on here. So for in this case, this is a first trimester pregnancy. And so usually, generally, if it's early on in the first trimester, you can see a yolk sac, sometimes even a fetal pole. And the whole thing that's black here is a gestational sac. I know some institutions do not do GYN ultrasounds. They have their, sometimes they may have not in agreement with their radiology departments, or they simply just don't do it, or they don't have patients that come in. I remember when I was working in another institution on the West Coast, I think in a year, I did 2 pelvic ultrasounds, I'm sorry, 2 pelvic exams, whereas I was seeing pelvic patients, GYN patients left and right when I was in New York. So I think institutions vary depending on what the practices are. Okay, so so this is a very, something you might see this. So a lot of times people ask, well, what's the beta HCG? You might have the radiologist ask you, or your GYN consult ask you, because they may not necessarily see it based on the level on ultrasound, based on the level of your beta HCG. So if it's too low, like in the 500s or something, sometimes we may not even see the pregnancy itself. So they usually bring patients back in to do a beta check in a couple of days to see if it doubles. And when it does double to a point where they could potentially see it, then it's better visualized in the ultrasound. So if you can see here under discriminatory zone, so what does that really mean? It basically means that in the discriminatory zone with a beta of 1500 to 2000, this is most likely where you will actually see the pregnancy between 5 to 6 weeks. So this is transvaginal ultrasound only, because transabdominal is much later, so it lags about a week or so. So then you have your discriminatory zone where you will most likely see the gestational sac. And then you have your upper discriminatory zone where you can most likely see the yolk sac. So generally, you probably won't see much of anything less than 1,000, but definitely you might see something between 1,500 to 2,000 for your beta level. So the differences between the transvaginal ultrasound and transabdominal ultrasound is really with dating, as well as with your beta level. So you can see here between the transvaginal as well as the transabdominal, it lasts about like a week to a week and a half or so, so that you can actually see it on your ultrasound. So the sequence of events in early pregnancy. So here we see a little blob. That really is just a very extremely small gestational sac that really doesn't, it's just an indication of where the pregnancy may be, but this doesn't necessarily mean that you may have a viable pregnancy or an IUP or whatnot. So this is just saying that there may be something going on and you might want to bring the patient back in to either repeat the beta or repeat the ultrasound, depending on the chief complaint of the patient. So by about 5.5 weeks, you'll start seeing the yolk sac, and by 6 weeks, you can see the embryo with the yolk sac with the fetal pole. And then between 7 to 8 weeks, then you can start doing some measurements of what you look like an early fetus. Any questions so far, just interrupt anytime. Okay, so this is a very nice image of what you would see on the sequence of pregnancy. So going forward, going from the top down, so the left upper corner is the first month where you see not much of anything, maybe like a yolk sac there. And then the second month, and you'll see definitely a yolk sac and maybe some fetal pole here, and then the third month and whatnot. So as you can see, as the baby grows, that you can see more and more to a point, by the time that you get to the end, all you really see on your transabdominal ultrasound image is really the head, not much of anything else, depending on where you ultrasound on the belly. Okay, so this looks like two eyes of an alien, but it's not. It's actually twin pregnancy. And I remember when I was doing my fellowship, we were doing clip reviews, and there was a patient who had twin pregnancies. And then I was with a bunch of, I would say, boys that was in my, we were doing clip review. And then my question was, how do you date twins? And they all looked at each other and they started laughing and giggling. And I was completely missing the point, but then I realized what I had asked them. And then they were just a bunch of like big boys that was making that joke. But I actually don't know how to date twins, as in like dating the age of twins, because I think that actually differs. So the dating of these twin gestations differs. And I think there's other components involved, but generally it's much easier to do it when you have one pregnancy versus two pregnancies. So when you do have a pregnancy, and it's far along, about 7 to 8 weeks, you may see a flicker in your fetal pole, and then that may be an indication that the development of heartbeat, so they can obtain a fetal heart rate. So what you do is that you actually do an M-turbo mode right over where the flicker may be, and then you actually can capture and calculate the fetal heart rate. So when you do this, you might see a repeating pattern that's at the bottom as indicated by the arrow here. And then what you can do is to just do a measurement of the repeating pattern to get a rough estimation of your beats per minute. And then almost all the ultrasound machines can do this, and sometimes they may even help you detect it. And then so in this particular case, you go from the beginning of one repeating pattern to the beginning of the next repeating pattern. And in this case, this heart rate is 122 beats per minute. Okay. So sometimes when you get to a point where you start having these, really defined architecture, then are no longer in the first trimester. But it's just interesting to see as well from a fetal heart, but this is really out of our range. So pregnancy here that you can see, but you're not sure if this is like a yolk sac or not, but you realize that something is there. So when you do I always start with a transabdominal ultrasound. If I don't see anything or something suspicious, then I can go for the transvaginal ultrasound. And sometimes you may or may not necessarily see anything. And these are just different images of what you will see for pregnancy. So sometimes you just see a gestational sac, and then sometimes you might see a yolk sac there. You must really see a yolk sac to be able to quantify it as the IUP. Okay, so in these cases, sometimes that it would be important to see if it really is an IUP. And one way that you can actually do the measurement is to measure the endomyometrial mantle, which should be really be more than 0.8 millimeters. If it's less than 0.8 millimeter, then there's a high suspicion that this is actually an ectopic pregnancy. So for example, this pregnancy, you know that from all the previous clips that I've shown that this is the uterus. And then you know that this is myometrium, this is the endometrium. So I would expect my gestational sac to be right in the middle of the endometrium. But what's this? What's on the side that looks like a gestational sac, but you're not quite sure. So you measure the endomyometrium mantle, which is from the very bright part of the edge of the gestational sac all the way down to the end of where your myometrium, your uterus is. And in this case, you measure the thinnest part. And if it's less than 0.8 millimeter, which is in this case, I'm sorry, this is probably a mistype. This is actually supposed to be 8 millimeter. And so, or like 0.8 centimeters. But so if it's more than, if it's less than 8 millimeter, then it would be suspicious of ectopic pregnancy. So I'm gonna have to change this. So in this case, this one is actually 3 millimeter. So this is a higher chance of ectopic being an ectopic pregnancy. So this is another measurement that you can see here. So here's the uterus, and then you have the endometrium, and then and you measure from the endometrium all the way down to the edge of the myometrium, and this is how you do a measurement for the endomyometrial mantle. So in this case, they measured it and it's 1.3 centimeters, so which is above the 0.8 centimeters. So therefore, unlikely this would be an ectopic pregnancy. So again, looking at this, if we were to measure the endomyometrium, so you see the uterus here again, because if you squint a little bit, you can see the little stripe here, but there's no pregnancy there. The pregnancy is actually over here. So you're suspecting that this may be an ectopic pregnancy, and there's some dots here indicating is this in the uterus? I mean, sorry, in the ovary, I'm not quite sure. So then you would actually do your endomyometrium measurement, which would come from the very edge here on of the gestational sac all the way down to the end of the end of the myometrium. So other images that you may see for ectopic pregnancy, this is an ectopic pregnancy involving the cesarean scar. Again, you look for where the uterus is. If it's not there, then it's somewhere else, then it's an ectopic pregnancy. And here's another cesarean scar ectopic. And so you look for the interstitial line of your uterus. And if the pregnancy is not there and it's somewhere else, it could be an interstitial ectopic, which is in what's happening in this case. And there's some free fluid here. I think it's free fluid. A bladder looks like free fluid. Okay. So, so once in a while, you have patients that come in who's in the first trimester who's complaining of vaginal bleeding. And when you do the ultrasound, you notice that. So you identify the IUP, there's a yolk sac and there's a fetus here, but then you see some of the dark spot over here. And this is what we would call a subchorionic hematoma or subchorionic hemorrhage. So most of the time, the body will absorb it, but there are indications that the bigger this volume is, the higher the chance that the baby may abort and worse prognosis. But usually this is actually a pretty big one, and here too. But most of the time it's actually quite small that we see. So this is what it looks like. So subchorionic hemorrhage right near the placenta within the uterus itself. So with subchorionic hemorrhage, usually coming with vaginal bleeding, about 10 to 20 weeks gestation, and it does occur about 11% of the pregnancy during this time. And you actually measure it on ultrasound based on the size to the gestational sac. So if it's if this small, it's less than 20% of the volume of the gestation, when you do like a rough comparison with the gestational sac, chances are you're going to be okay. A little bit more worrisome, between 20 to 50%, and the bigger it is, the worse prognosis. So going back and look at some of these images. So this is what I normally would see. I see a pregnancy in the middle and then just some scant bleeding around. So this looks like it's small. So chances are your body will absorb this and you just follow it. So we've also seen molar pregnancies and or partial hydatidiform pregnancies, and I think depends on the chromosomes. And then so what it looks like is that just these little dots, you see your uterus, but you see these irregularities within the uterus, and then that the pregnancy test is positive, and then that you measure the beta HCG and is elevated. So then it's very highly suspicious for a molar pregnancy. So molar pregnancy, this is a partial molar pregnancy or a partial hydatidiform pregnancy. They have a higher risk of developing chorioadenoma later on. So these patients do need to be followed very closely. So sometimes when I actually don't see what I want to see on a transabdominal, if I do a transabdominal ultrasound and I see a gestational sac, but I don't really see the yolk sac to convince me that this is going to be an IUP, then what we can do is use a linear probe. So this is a trick of the trade. So on the left that you see a transabdominal probe, but you don't really see the yolk sac. So when you actually do using a linear probe, then you actually visualize the yolk sac much better. So this is one of the tricks that I like to teach the residents. So they actually have done several studies on this, and one of the ones that came out in 2016 that actually had a bunch of patients that were enrolled, and then they found that the ones that they did a transabdominal ultrasound, they found an IUP, great. The ones who didn't do did not visualize an IUP, they actually did a linear probe on these patients, and then saw some of these patients also with IUP. So it really reduced, the conclusion was that the linear probe actually reduced the need for transvaginal ultrasound. So this is more for the comfort and also for the diagnosis for the patient. So again, this is a transabdominal probe. On the left side, you see a little something over there, but when you actually use a linear probe, you actually see more visualize the yolk sac. So going into the ovaries a little bit. So this is what your ovary would look like. This is a transabdominal probe if you look at the footprint on the top. So you see the bladder and the uterus, and on the side that you see the ovaries. So I don't consider myself an expert GYN ultrasonographer. Simply, I just identify as an IUP if it's not IUP, and then that's about it. And we look at the fetal heart rate and if there's anything that's abnormal. But generally, we back it up with radiology as well as with our GYN consults that will help aid us. But sometimes if we do something that's maybe questionable, or then we definitely want to follow that up with the experts who actually does this on a regular basis. So when you do ovary ultrasounds, they're supposed to look like chocolate chip cookies. And this is a fabulous image of it, but do I actually always see it like this? Most likely not. What I like to do in these type of images is that I actually like to start with transfers. And when I'm doing a endocavitary probe approach, transvaginal probe approach, I go in and I do a transverse and I look to the left and I look to the right and I actually try to follow the fallopian tube and then try to milk the ovary down with my other hand to see if it comes into view with my probe. And that usually does the trick for me to find the ovaries. And then so this is what it normally looks like. It's a cross section. What we're seeing here that looks like follicles or chocolate chips is a cross section of your ovary. And this is what a polycystic ovary will look like. This is very exaggerated ovary, but this is a cross section if you can think of that. So sometimes you may see on this left side that you see this dense thing on the right of the patient. So it's this ovary, is this normal ovary? It's hard to say. So oftentimes, is it flowing? Are they having pain over there? You have to also correlate it clinically. But oftentimes we would do some measurements. So if you're having pain on that side, and if you're doing an ultrasound, and if your ovary, your overall ovary, including any cyst or anything suspicious there within the ovary, is over it's over 5 centimeters, then your chances of having torsion is a little bit higher. If it's really, really big, then sometimes it came in torse because it's so big, there's no way to torse. But generally, if it's more than 5 centimeters, then it's a higher chance of torsion. Okay, so with ovarian torsion, it usually occurs between 15 to 30 years old, and it actually occurs about 20% during pregnancies. And then that may mean that your ovaries are hypermobile, which I never thought that it could be. And then sometimes you could have a related adnexal mass associated with it. So here's an example of an ovarian torsion, the one on the right side. You don't see any flow to it, but the right on the right, you actually do see the flow. So this is very similar to how you would do like a testicular ultrasound looking for flow and whatnot. But this is something that I would definitely let GYN or your radiology department perform to look for torsion or not. So once in a while, patients would come in and they would say, I got an IUP place and now it really hurts, take it out. And I tell them, I said, I don't take out IUPs in the ED, but I can look to see if it's bothering you in some way. So sometimes you do a transabdominal or a transvaginal ultrasound and you can visualize the IUP. So here is I'm not IUP, IUD, sorry. So an IUD inserted properly within the uterus should be along where your endometrial stripe would be. So if it's not properly inserted, the IUD can be dislodged, and it can actually penetrate or even perforate your uterus in this particular case over here. So this needs to be really removed. Okay. Here is definitely dislodged. As you can see, even perforated the uterus. So the symptom can be pretty dramatic. And so here also, this is the previous views have all been sagittal view, whereas this one is a transverse view. So when you do a transverse view, you tend to see just a little bit shadowing and a little foreign body appearing type of material. So generally the IUD would be where the endometrium would be followed by that arrow. But then in this particular case, it's actually below it. So that's not where it's supposed to be. Okay. So once in a while, we also have patients coming in who are preteen or at early teen, complaining of abdominal pain, but really hasn't had their menses, and they would have frequent abdominal pain, but just generally like cramps. They would happen, for a few days every month for the past several months. And then, so when you actually do the ultrasound, you can find imperforated hymen with the hematoculpus. And then, so this is more of a surgical issue that you would deal with the surgeons, but also interesting to find if you do find it. Sorry for the noise. And so hematoculpus here as well. So it generally looks like sometimes they may layer depending on where it is. And then here's the measurement here. Fibroids we don't really see at all in our pediatric world, but once in a while we can find them, and this is what it would look like here. Just wanted to show you all. And when I was doing this talk, I found this really great site that VDen actually has under POCUS 101. Pelvic Ultrasound Made Easy has really great references for people who actually don't do this often, but just want more of an insight on how to do it. So, and lastly, this is at one of the AIUM conferences when I brought my children, because they too also want to learn how to do transabdominal ultrasound looking for babies. So. And I think that's it. I'm just going to just put myself on mute because I see that we're constructing. So any questions that you have?
Hi, Ee, that was great lecture, by the way, great reference. So really glad you did that. So a couple of questions on the chat. One of them was, what settings do you use for the linear probe when you switch over to see pregnancy?
So what settings? I generally just use small parts. Is that what the question is? Let me go look at my chats. I generally just use small parts. Yeah, that's it. And then I just go as deep as I can until I find it. Did that answer the question? Okay.
Yes, I believe so. Yeah, that was some chatter in there.
Yes,
well.
Thank you.
Okay. Let's see. We did a journal club on beta ultrasound visualization, and bottom line takeaway seems to be that beta of 0 was the only reliable thing. Yeah, most likely, probably, but I would probably, it depends on the patient. If they're coming in for abdominal pain, definitely still do a beta check on them as well, because you never know if it's an IUP or if it's a heterotopic ectopic pregnancy. You can have one ectopic and one IUP and whatnot. Yeah, EM docs should not counsel patients for adverse outcome. Yeah, I never really want to be the one to tell them that. So yes, I leave that to the professionals, the GYN doctors. So the linear probe, let's see. So the Doppler models with the thermal index. So I don't do color Dopplers. I simply just do M modes. For looking at the fetal heart rate. I think that might be a little bit different. I know we are always taught not to use the color Doppler because it heats up the fetus. But in all honesty, when I was pregnant with my 3 kids, every time I went to go get my pregnant ultrasound, they were just Dopplering me left and right. So I think my kids turned out okay, but I don't want to be the one who's going to burn up somebody's baby. And I know, so why aren't there any OB settings in the phased array probe? There is, depending on your machine that you're using. And I think those are my questions I'm trying to answer. Any other questions that anybody may have on this?
I got a general question. So how often are people are doing endocardiary ultrasounds? I find that I rarely do them. I do a lot of transabdominals, but I don't do a lot of endocavitaries, so I'm not sure what the others in other institutions or practice is like.
Yeah, I'm curious to know too, because we do them fairly often, but from time to time, but I'm curious to see what other people are doing.
We have had chronic problems. Erica from Hasbro Children's in Providence. We've had chronic problems with cleaning our probe and who's responsible for cleaning it. And so it's basically out of service because we can't figure out a good cleaning protocol for endocavitary. That plus on the pediatric side anyway, there's very little need for it. So we haven't really invested in it. But on the adult side, they have one, and that's their problem.
Yeah, I have a whole other lecture on just cleaning probes. So maybe we'll do that at another time. So some institutions, they do have a whole protocol associated with it, depending on how you clean it. We for some reason, our institution, because maybe we take care of a lot of like an inner city population with a higher pregnancy rate for younger individuals, so we do see them a little bit more often, I think.
What's your cleaning protocol for your probe?
So we do spray it down with this solution that our central supply gives us so that it doesn't dry out the probe. And we wrap it in this sheet thing, this plastic bag. So they're deemed like hazardous material in a red bag. And then we actually call central sterile to have them come in to clean it. And I think they actually put it in that, that machine where they do the UV thing that I don't really remember what it's called. Once that's performed, then they would bring the probe back down for the next use. For other institutions, what we have done before when I was in another place, that we did have a solution that we dipped it in, but that's really not reliable. And the protocols all over the place and not everybody did it correctly. So I think it was more standardized through central sterile doing it rather than the ER people actually trying to clean it. So.
And based on the chat, it looks like Yale doesn't do it. As Rosemary from there, they don't do it. And then also Cohen's, they don't seem to have a endocavitary probe either. So yeah, we have an endocavitary probe. We use sterile processing to clean it. Since we just brought a new machine, we used to have two, now we just have one. But you know, I rarely use it to the point that for transvaginal use. I use it for endocavitary PTAs, I think, more often. But that's sort of my, like where at my shop.
I was going to ask, how do you guys do PTAs? I mean, there's ways of doing it through a linear probe, but the image that you get using an endocavitary probe is so much better. However, it's hard to have an endocavitary probe inside your mouth while you're also trying to do the excision and draining at the same time. Quite challenging and cumbersome. So it's more like a two people kind of a thing, but you could use a linear probe for that. But I find the images and using the endocavitary probe is much better. So Trophon, that's what it is. And you know, I think we actually use a Trophon, but that's by central sterile when Stephanie had mentioned this. So, so Leigh says it causes cancer. What causes cancer? Trophons?
I was going to ask him the same thing.
Oh, that's not even funny, Leigh. Yeah, sprays. Okay, anything else? So this is just a quick overview. I know we all don't do it, but we do. And I find it to be just an additional resource that we have so that we don't have to wait for OB to tell us whether or not if you have an IUP or not. So.
Yeah, this is great. Thank you. You know, it's a great reference, I think, for me, you know, quick reference to go back to, especially for my fellows, because I said we don't do them some often, so they do it more when they go to the adult world. So I think this was great. So thank you for going over through everything. So it was very helpful for me.
Okay, you're welcome. And if there's any other questions, you can always feel free to email me. So
Ee Tay, I have a question about your cardiac standstill project. Where
Oh,
are
yes.
you with that?
Oh,
I was
yes.
curious about the results of it.
Okay, so for those who may not know, so the fellow and I are doing a cardiac standstill where some of you may have received this, or me bombarding you guys going, fill out this survey, which is we give you 11 clips and then various cardiac standstill, and then you have to tell me whether or not if you believe that this is a cardiac standstill or not. So we actually, interestingly enough, I just went over this with the fellow yesterday. And then so for the most part, the fellows with their, so we're looking for a real like agreements between people who they think of as standstill. So amongst the fellows, they all have agreements, and then for the attendings, it really varies. But the attendings that have done what we consider experts, as in 25 or more cardiac ultrasounds, they all have good agreement. But the ones that have never done ultrasounds or have only done one or have never done resuscitations with ultrasound, they have very poor agreement amongst each other. And so which is expected. But there's a hope towards the clip, I think 9, 10, or 11, there's people were all over the place. Some people agree, some people are not. And then we're trying to figure out why is there so much variability? So we have to really look at the things. Is it like the blood is swirling in the, or like the valve is flickering but not really moving, or like the wall motion is slightly there but not there. So we have to go back and take a look to see why is there not variability in some of these clips. But just for you all to know that, and I don't think we told anybody this when we did the study, all those patients actually all expired. So they're all at some point had standstill, just depending on how long that you want to resuscitate them.
Thank you.
Did that help answer your question?
Yeah, I was super curious because, you know, in our adult colleagues, they routinely use POCUS as part of their resuscitation decisions, and we don't as much, even among my POCUS colleagues. So I was curious what your study was going to say.
Yeah. So what we're in the middle of trying to write this up for SAEM and PAS. So we'll have more data in the next coming weeks when we actually analyze them fully. But I think what we're trying to do is to really divide them up in terms of the clips that actually had wall motion versus the ones that had no wall motion, or like valve motion or no valve motion, and to see what the interreliability agreements amongst the physicians. But generally, if there's movement, people are like, oh, they're going to continue the resuscitation and not, it's not a standstill. It's the one that has zero movement people have more agreement on. So it'll be interesting. You should look out for that publication coming up sometime next year.
Thanks.
Any other questions? Well, thank you so much for having me.
Yeah, Ee, thank you so much. And I look forward to, for you to present to us in the future. Thank you so much.
Okay.
Thanks, E. Great job.
Bye.